Oh, okay. All right.
Oh, I already know.
The crust doesn't seem nearly as bready as it was last week.
Still pretty bready.
It's still bready, but it doesn't seem as bready as
So
last
it's
week.
in between
We could have cut the
last week
pieces.
and the week before.
Could have cut the pieces like half today.
Yeah, we're gonna complain about
I think they got closer to cooking it.
Like I have a mental hang up that I'm gonna have 2 pieces of pizza.
it. Right.
And if they're huge, it's like,
Yeah.
I still have to have my 2 pieces of
We're gonna
pizza.
complain about that because they cut pie into 6 pieces and
Yeah,
that's
that's not
ridiculous.
good,
Like,
It was like New York style. They like folded it and stuff.
their
and it'd be okay.
inconsistency is.
There's a knife somewhere.
Yeah, like
In the
that.
restaurant, Rocky Brook Cocoa.
Yeah.
People want to know.
Alright, so, alright.
Rocky Brook Cocoa. I don't know, I haven't had it. So.
Alright, so welcome everyone to the Tools and Technology Seminar Series. I believe you've all been here before. There is a sign-in sheet going around, so please do sign in. It just helps us with the pizza. As you noticed, we're continuing to trial out M-Dining for our pizza vendor, so we're continuing to give them feedback. So if you have feedback that you've not already provided me, please feel free to do so, so we can see whether or not we will continue to use them. So today I'm pleased to introduce our speaker, Dr. Chuck Mayo, and he is an associate professor from radiation oncology, and he's going to talk to us about big data and radiation oncology.
Great. Thanks, Marcy. Pleasure to be here. So, first acknowledgments. I get to work with a large group in radiation oncology. This group has a long history of pushing the envelope in radiation oncology with development of informatics as radiation oncology has evolved from its infancy. And it works through physicists, physicians, staff members, so it's really a terrific group for what we're able to put together. There's going to be a couple of common themes that I'm going to touch on that we're finding as we engage with people at other clinics who are trying to accomplish the same sorts of goals that we're doing, that really come through a lot. One of them is community science, that a lot of what we're accomplishing in radiation oncology and what becomes the basis of it is working together with groups, not just team science, not just the people right around you, but reaching outside. Fortunately, it works in our group that our department has an unusually high ratio of people that work to reach outside the department to form communities to do that. In those efforts, we're always looking for the win-wins. That's how we find the ability to construct something that will work. One of the reasons we're really excited when you gave us the offer here to speak a little bit about what we do is to recognize, as we're engaging with other people, helping them, and they're helping us, there's a real need to understand one another's domains and what are our problems, how are we approaching them. A lot of times what happens is that what happens on the clinic is really very interesting, but it doesn't quite connect with what happens on the academic side. So I'm really hoping one of the things that might come out of this is that we can start bridging that gap a little bit, and certainly by showing you, giving you a better sense for what we're accomplishing, maybe that'll help. So radiation oncology, you may not know very much about radiation oncology as a specialty and what happens in the clinic. I want to give you a better understanding of where we're coming from as we're addressing big data, how that fits into it. Radiation oncology is one of the most data technology-driven specialties in healthcare. So what do I mean by that? For our patients, we are delivering radiation to kill cancer cells. Radiation kills cancer cells. It also kills everything else. So hopefully what you're trying to do is take advantage of them being a little more sensitive to the normal tissues around them to be able to deliver a lethal dose to the radiation, spare the other normal structures around them. But then to do that, we need to use some fancier techniques. So we don't just point a beam and shoot and say we're done. We have to find ways to sculpt dose surfaces as we go around. So for example, here, we've got a patient with a brain tumor right in here, okay? And we want to deliver a high dose to this. What's the problem? Optic nerve and chiasm is going right through in the middle. So one of the things we want to accomplish is to be able to deliver a lethal dose to that tumor, but not make the patient blind. Now that's not easy to be able to pull that off. You can't just point and shoot and do that. It's going to cover everything. So one of the things that we do is we have these devices called a multi-leaf collimator. These operate under computer control. So we have this patient's being treated with 4 arcs. There's one that rotates all the way around the head. There's one that does an arc this way, an arc that way, and an arc this way. As they rotate, these leaves are moving, so we're modulating the intensity so that we can sculpt a dose surface that helps us deliver the dose to the target and avoid the tumor. Now, back to, what's that?
Avoid the normal.
And avoid the normal. Thank you. Sorry. Don't want to avoid the tumor. Now, back to radiation oncology being data technology driven. How is that done? Well, everything here is happening on a computer connected to a database. All of this information, which beams are going to be used to treat, are all plugged into the database and quantified. So we have a wealth of information about how the dose was delivered, how those leaves were controlled as we treated the patient. We also know a lot about the doses delivered to all of these normal structures. So these are each quantified as well. Although one of the things, and I'll come back touch on this later, that we deal with is this text field is free text. This down here is fixed and quantified. So we have a mixture of things that get manually input and things that are just fixed that we have to mine. When the treatment's delivered, again, it's a team approach. So the physicist or dosimetrist will run that treatment plan. On the delivery side, we have an accelerator that's generating the X-ray beam that comes in through the head here, and the leaves are up there to modulate it. The patient lays on the table. Our therapists, here we have Phil and Bonnie, who are treating patients. Notice the computer screens they're surrounded by. So at every step of their process, whether we're talking about appointment types that are being entered in, tracking various outcomes, that's all entering into a database. So what are the problems that we deal with when we're thinking about our patients? So the point is, we want to treat the tumor and spare the normal tissue. Did we succeed? What are the issues involved? Here's an example of a patient that's being treated for a mediastinal tumor here. Okay, so we need to deliver a high dose to that. Thank you. Right. Yes. Sorry. So we want to treat this tumor. We don't want to deliver too much dose to the heart. That's a few slices down. We also don't want to deliver too much dose to the lungs. If you deliver too much dose there, the patient gets pneumonia, and they can die of the pneumonia. So you don't want them to die of that. So we have to find a way to spare those normal tissues. So this will be one of the things when we're going back and looking at our patients and saying, how did we do? We'll be looking at those doses and saying, is there a place at which we saw a trade-off where we did a little too much on the lung and now we're seeing a complication? Another site where this comes up is spine. So this has been a treatment that has become much more frequent in radiation oncology clinics in the last few years. So a patient is treated for one tumor site. Cancer is an awful disease. It metastasizes. Often it metastasizes to the bone. It may land in the spine. That's extremely painful. So stereotactic radiosurgery is a way that we, again, sculpt very sharp dose surfaces to be able to treat the tumor that has landed there, but also spare the cord. So we're going to be asking questions about how are we doing on sparing the cord? Are there any complications that resulted from that? So we have to connect the dots. I know the dose. I know that really well because we quantified it. How about the outcome? How do we know that? Can we connect it up? Does it matter? What are the other factors? So that will come in there as well. This is Avi Eisbrook. Avi is one of our physicians and one of the world's experts in head and neck cancer. So people come from all over to be treated by Avi. And this is typically what happens in clinics now, is a patient comes in and the physician is really at the middle of pulling all of this information together in their wonderful brain. All right, so they'll evaluate the options, they'll design the treatment, they'll deliver the outcomes. Some patients are on clinical trials, typically about 3% nationally, not much compared to what happens routinely. Those patients we know a lot about. So they gather lots of labs data, lots of outcomes data, so you can connect the dots. They know those pieces. But we treat every patient, right? And a lot of our data is already in the computer. We really ought to be able to be in a position where instead of dealing with a few patients, that we can start dealing with thousands of patients in our own institution, or being a community and reaching out and finding data sets that are tens of thousands. So ultimately, we'd like to get to the point where the physician then, this is not the linchpin, that we are gathering for each patient that comes in. We gather the information, we measure the outcomes and treatment for all of our patients, and aggregate that into a common source, pull in data from other specialties, and then use automated approaches to analyze it, carry out machine learning and reporting so we can participate in registries, and then have that information feed back in this loop so that for every patient that comes in, their information becomes something we can use to improve for the next patient that comes through. This is Marie Curie. So when I think about what we're trying to accomplish in looking how to close that loop and what we want to reach toward, the effort is very early on. And Marie Curie is a physicist. The curious thing when you go to read Marie Curie's thesis is it's not so much about physics. It's more about industrial chemistry. So in this earlier age, they wanted to understand what was happening in radiation, or what is this thing called radiation. But to pull that off, she needed radioactive isotopes. You couldn't just order them. So her effort really required extracting it. So she's mostly spending her time in her doctoral work doing industrial chemistry, figuring out how to take truckloads of pitchblende blocks or rocks and extract out of them the small nugget, the thing she really cares about, in order to carry out her experiments. Not too dissimilar from what we're trying to do in radiation oncology. We have a place we want to be. We want to reach that goal where we can close the loop. We're gathering all this information and building it into our database systems, building automated tools to analyze the data. But we're first going to have to go through the work of figuring out how we can get to those pieces that we need. So that's a lot of what's happening in big data in radiation oncology. We've taken a look at what we need to do. How do we need to stratify our approach so that we can start taking these things on one by one? Down here is the clinical practice tier. So we have many, many data sources. So there's not just one. You have a question, and we'll talk about this a little later. You have a question, you want to answer it. Where are you going to get the data to answer the question? It's not going to come from just one system. So some are organized in databases. Some sources are spreadsheets. It's amazing. The genomics data shows up in a spreadsheet. The laboratory data comes from another database. There are multiples that we need to be able to pull from. So to be able to answer questions, we have to be able to connect them up. You have to know how this relates to that. We need to know not just the key data elements, but how they're related. So we need to pull them together into the aggregation tier, into a common database system. Now, that's a place to organize the data. This process is really about reducing entropy in the data in that first step. Now that we have it, we can start thinking about common standards for how that information can be exchanged and used in a variety of analytics tier approaches. So we can do machine learning. It ties us into clinical trials. So there's quite a lot we can do here once we're able to get the data transferred over and establish some standards for how it goes, so you're not spending all your time figuring out how to make two things communicate. Now what we expect coming out of this, as we learn from this data for our patients, this turns back into how we affect our interfaces, what information is going to be communicated, and then how this information comes back to inform what we do for the next patient, so the evidence-based decision support. So when we're trying to find meaning in what we're doing, and to find meaning in these large data sets, we really need to have depth in our cofactor profiles and domain-specific detail on key data elements. A lot of times when we're sitting in the audience listening to big data conversations, this sort of sits in the back of our mind as we're thinking about meaning, because we're asking if the patient had a toxicity or they didn't survive, the question is why, right? So if you're doing a big data study and you're tracking where patients or people are traveling in Ann Arbor, suppose you're watching GPS coordinates on Uber taxis or something, you may learn a lot about where people go. But if you want to ask the question of why did they go there, why did it happen at this time of day, why this particular part of the month is it different, you need to be able to answer questions. Is this the mother who needs to go pick up her kids, somebody going to their work, are they late for their job, is this about healthcare? What are the issues that they're dealing with? So we need depth in those cofactors to be able to get to the question of why. And we need to have domain-specific detail on those elements, because you can't trust them. Just because it's there in a database doesn't mean it's correct. So if you don't know the vulnerabilities of that data, you're going to be undermined in what you can do with it. So for example, if you're tracking GPS coordinates to look at your location, that works great when you're out in the suburbs and you're going to land at a mall, I know where I am. But if you go downtown, where you've got a high density of storefronts that are also vertical as well as laterally distributed, you don't have quite so much information. So understanding the implications of that detail is really important. In radiation oncology, we have to do a lot of that. The questions that we want to ask cover a wide range of categories. Treatment and dosimetric information are in our domain. We can control them. But we need to be able to pull information on demographics, imaging, chemotherapy, surgery, pathology, labs, a wide range of information. And a variety. How does it get in there? A lot of it is manual entry by a variety of people. Even labs are not manual entry, but you'll find as you start to go pull that data that when you're looking for a particular lab type, for example, one study we're doing right now is looking at liver response for patients who are not having cancer, need to track albumin scores. There's 5 different ways of designating albumin scores. You only want one of them. And we find as we were pulling this information out of EPIC, that's where labs is and a lot of the information, one of the things you learn as you work with multiple institutions is if you've seen one instance of EPIC, you've seen one instance of EPIC. And so as we're starting to think about this community and how we're pulling this information in, this is a fact about the detail of our data that we have to be aware of in our communications with others so that we can, if we want to develop a common approach so we can get to that goal of a data set of 10,000 patients, then we're going to need to be able to reckon with those factors. Another data element I'll point out too that is emerging is radiomics. So this is a slide from Issam El-Nak, who's one of our faculty as well. And so in addition to the labs measures, we're starting to take texture measures from the images and incorporate that back because he's learning that he can take this information that he gets about intensity distributions of the Hounsfield units inside of here and relate that back to response of the target or the tumor and how it might respond. So there's really a very wealthy set of cofactors that we need to track if this is going to work. So one approach, and this often happens when we start talking with people in the clinic, right? They want to get to using the data. They don't really care about how you got there. They just want to use the data. Well, it's all in EPIC, or it's all in our electronic. It's all there. It's just ready. Take a dump, and it's ready. In fact, there are vendors who will advertise they can do that. Just upload your data, and we're good. Not so much. We find as we go through this that a lot of data sleuthing is required for us to understand what's happening with our data before we can start approaching the big data question. So we have to know, what data do we need to answer that question? What are the relationships? Where is the data, and can we get at it? Who am I going to have to talk to? What relationships are we going to have to foster in order to be able to get to that data? And then what are the vulnerabilities in the data that can undermine some of those conclusions? So let's take a look at an example. It's a very simple question. What are the rates of survival and recurrence for patients with stage 3 nasopharynx cancer? Okay, it may seem like a like it's a little specific, not too much, but head and neck cancer, how do they do? You treat them, how do they do? Rate comes up, that's interesting, right? You can get a statistical measure of what happens. And this is from a publication from that other state in Cleveland Clinic there, and they do this wonderful thing. Every couple of years, they will publish survival curves for all their disease sites. Fantastic. You don't see that very often. But you notice one thing. So this is from 1996 to 2012, 56 patients. They probably treated more than 56 patients. And what this goes to is how hard it is to get to this data. It's not lack of trying, it's just this is not an easy question to answer because there's a lot of pieces that you have to deal with. So when you're looking at the rates, first you want to make sure that you've got enough numbers to be able to really talk meaningfully about the rates. How do I know they have stage 3 nasopharynx cancer? Is there a line in the chart that says, no, there's not? It may be difficult to even figure out if they're head and neck cancer patients. So how is this designated? Well, there are a couple of things that help you. We use codes that are used for diagnosis, codes that get associated with billing. They get manually entered. They don't always get entered correctly. If you're looking at the diagnosis and staging, so diagnosis, it's head and neck, it's nasopharynx cancer. Staging, how bad is it? That often shows up as free text. And guess what happens when it's free text? It may not be right. It may not be entered in a consistent fashion. So if you're going back and you're combing through all the records, you've downloaded, you've got all those text records, you want to find them. If they're not represented in a uniform fashion, then it's going to be very difficult to be able to pull that back out. You don't know if it's complete information. So we have to deal with all those problems. Survival and recurrence, right? That's our outcome. That's our question. So we go back to our treatment planning. I know an awful lot about the dose. How'd they do? Survival, recurrence, does the disease come back? That information, the recurrence, shows up as free text as well. Not consistent, not necessarily in the same place, not necessarily expressed in the same way from one patient or one physician to another or from the same physician over time periods. Survival, how do we know that they survived? They don't always come back, right? Maybe they go to a different hospital. So now we're starting to get into questions of how do we get information when people go somewhere else? And we're dealing with privacy and compliance. For some of our researchers, when they get to survival, what they've resorted to is they have people who are looking through Facebook entries. Things like that. They're looking for an online profile. Unfortunately, that reveals one of the other issues that you have to deal with is bias. Because if you're looking at your data, you have to understand your data details. Does the data that you're able to get also reflect a bias, right? You're only going to find Facebook for people who are interested in being on Facebook.
I'm still alive.
What's that?
Still alive.
And still alive, right. So.
If you're dead, you stay on Facebook.
And you vote in Chicago, right? So.
I know people have passed away and their significant others have maintained their Facebook presence.
Yeah, right. Yeah, those nasty details. So you can't, with the big data, you can't just, I got this download of data. It must be right. I can go make conclusions based on it. The need to dig in and understand where it's going to bite you in your analysis is really important. So we spend a lot of time doing that. So, so as we're trying to approach this and build these systems, we ask, what's the productive conceptual framework? How do we go about thinking about what we want to do with big data and radiation oncology? Right? We want to get to the point where we're doing analysis. We recognize we have to get a lot of a diverse set of data to do that. Data mining is a common way of thinking about it. But the thing that implies, kind of like Marie Curie's pitch blend, right? She didn't make the uranium or the polonium. She had to go figure out how to get it back out. She had nothing to do with it, with its creation. In healthcare, we are both the creators and the consumers of our data. So it doesn't just lie there being made. In the physical process, the mining, it's made in the same way over eons. In the human process, it varies day to day on how that data may be entered. And it may vary across practices. So for example, I'll tell you what data set we've got. We're pulling information on BMI for our patients. So height and weight we need to know. And in one of our data sources, we go back and pull it through and discover there's a 14-foot patient that shows up, and every time he comes back, he's 14 feet tall, right? And what does that mean? When you dig into the data, it means every time they pull up the chart, they just hit the button and they never look. And that's just a normal human thing, but it means it's a detail you have to understand about your data. And if going forward, you want to be able to rely on that data so you can get to the point where you have that automated system we were talking about, right? We don't want to have to manually do this. We want it to do it every time. Here, Avi, there's a pattern showing up in your data. You ought to go look. Then we need processes that are going to be pretty reliable in how that data shows up in the first place. So it really has to go to something more like a farming model. So a farmer is thinking about the yield of their production and everything they're doing. How is it going to result in more? The row is interesting. If you think back to early farming, right? They scattered the seeds. Now we have industrial farming. That simple concept of organizing things paves the way for being able to construct machines that can reduce the labor and expand your scale. So it's very similar to what we're recognizing we have to do as we're dealing with our data in radiation oncology to make it useful. The question of dirty data comes up a lot in discussions, and usually what happens, people will represent that you don't need to worry about dirty data. The problem, with that perspective is it assumes your question is over here. But a lot of times our question is down there in the tails. So I want to find the one patient where there's this set of cofactors that resulted in a complication. And we want to be really sure that's correct. And so having noise in that data means that all the people upstream who do this, they'll look at it and say, big data is a waste of time, because look at this. This makes no sense. So a lot of our questions are down here. We have to organize that. I'll give you an example. So at another institution, we're able to pull data, pulled all the toxicity scores. So in radiation oncology, we rank the scores. So for pneumonitis, is it not so bad? Grade 0. Or no, not bad at all, grade 0. You're dead, grade 5. And then, so it goes from 0 to 5 in between. So we were looking at skin toxicity, because sometimes you deliver radiation, you get skin toxicity. There were several grade 5 skin toxicities. Right? Come on, that can't be true, right? So that's somebody, there's no curation in that process. There's nobody going back. It's just their job, enter a score, they enter a number, it's grade 5. Okay, I picked grade 5. But if you're automating your system, that's going to hurt you, because those are the events you care about, not the low grades that everybody has over here. It's the high grades. So we have to start building in to our clinical processes abilities to check that data and spot when things are funky so that we can then be able to use it in the way we want to later on. So all of this points to a culture change in what we're having to do in radiation oncology, with getting people to recognize that the data we enter is what we have to do to get on with the business of treating the patient today. So historically, people would enter diagnosis codes. I got to have something to build them. It may not be right. I'm going to enter it in. And they do. But then, when we want to use that data, we recognize it's got to be what we use to improve the patient or the care for the patients tomorrow. And that's a real shift. It means more time for what people have to do. One of the things that we work on a lot is adoption of standards. Standards in practice, how we do particular things. And this is, again, another example of community science for what we do. So picking the wrong one. This is a foundation for us here, having these standards and making this routine. And as we start having this in place, then it becomes possible to make it routine to characterize our norms, develop analytics that we can use and automate to improve things for our patients. This becomes increasingly complex as you go up because there are more people involved. But it raises the value. One of the things we're doing, again, on the community side, in May, we're going to be having a conference on a practical big data workshop. So what we're doing is gathering together other groups from radiation oncology. Actually, it's international, so we have people from London and Netherlands coming, who are in the process of building these systems themselves, recognizing all of our lives would be easier if we had common standards for some of these key data elements that we need, and use that common standard to be able to exchange that information. This is part of what leads to the ontology around some of these items. And so our community is in a position where people are very ready to jump in and do that because they're recognizing the potential of what can happen with the big data if we get to the point where we start developing those common standards, so we can then get to the point where we automate construction of large data sets. So let me give you an example of what that means in our practice. So our physicians have historically entered the diagnosis and staging here as free text in the epic note. So as we talked about, there can be variability in what's entered, how it appears. At different time points, you may get different values. You don't really know. Here, there's no connection to what we did to treat, right? Two different databases. They don't talk, so how do they know? So we've shifted over into a process where we use quantified fields in the same system that we used to treat the patient. So now, every one of these values gets cross-checked against a standard reference. Only fixed values can be entered. It has to be complete. Notice this tells us the stage. This is grade 2. This is stage 3. They're talking about two different things, right? So that would be one of the problems with the free text approach. This is now telling us how bad the disease is. This is telling you about the characteristics of the cells and the histology. This is what we need in order to make that graph. So by transitioning to this process, we position ourselves to have better data in the long run. How do we get there? This wasn't about me doing this. So this was the community side. So this was some of our therapists who are real data geeks and are always combing through our databases to see how they can pull out information to tell us about how we can make our processes better. They're really enthusiastic about this. Our physicians who want to be able to use this data, so they really drove that process. So that's the side of the community and big data that matters to us. If we want to get to the point where we can analyze the data, we first have to reach in, understand the details of what the problem is, and then participate in the conversation so that the real stakeholders can drive the change that's going to make it better, so that we really can get to large data sets where things are automated. Here's another example. So this is a task group that I chair with the American Association of Physicists in Medicine. We take on the issue of structure names, right? So we have this great detailed information. We know structures. We know a lot about the dose. It's all in our computer systems. We should be able to then say, tell me about the last 1,000 patients. What was the dose to their optic nerve and chiasm? Guess where it falls apart? People aren't consistent about the way they name things. So and they may name things close. So there may be several versions of optic nerve in there. How do you know which is the right one? If you're going to ask the computer to go in and mine all that data, it has to know this one out, this one out, this one out, this one's right. If they're all similar, how do you know? If you're combining information from multiple institutions and you'd like to have an automated solution to gather that, how do you know? So one of the things that we've done here is brought together a community to be able to take on that question. This is one of the largest task groups that our professional group has ever had, actually, with 57 stakeholders. It's an international group, and it spans large academic, small community, vendor systems, trials groups, DICOM working group. So all these people who are grappling with the same pain, coming together saying it's in our interests to figure out a standard way of doing this. Even if we don't like what the standard is, the important thing is to have a standard, because it will let all of us go to the next step. And so this is one of those examples of where community science is factoring into what we're able to do with big data and radiation oncology. As we get to the point of pulling out the data, it's tempting to think it's all about the technology. Right? For us, we come and we go to these discussions. People talk about big data, and they have a variety of technologies they use. This must be what our issue is. It's not our issue. Our issue is being able to get at the data. Because it's complex, we have to negotiate with multiple groups to be able to access that data. When we get it, we've got to figure out how to clean it up. So all these ETLs are really what mark whether we're going to be able to be successful in getting the data sets we need. We have a database now that encompasses all of our patients, so 18,000 patients. We have a wide variety of information. We have more on some elements than on others. So this is a process. Right? So get the data, use the data, prove value, repeat. Right? And we just keep doing that through all of these these data elements to be able to pull that information. And so the challenges can be, inconsistencies in how it's laid out, unstructured free text, that's really a tough one. Changes in time, in the format, quality, and detail, right? So the data in this period of time was kind of odd. This one is okay. How do we spot that? Because we don't want to be thrown off. So we've got, for example, dosimetric information that for a period of 2 months in 2005, in one particular field, it's just whack. And there was something going on with the way it was being transmitted. But you have to look into the detail of that data to know it so that you don't try to factor it into your analysis. So we work through all of these processes, and then we process, we pull it into a data lake server. This right now is 107 gig. So it's not huge, but it's everything. It gets processed and cleaned up. So some things that are in the fields are not the thing you want to know. So for example, I want to know if this is an IMRT field. There isn't a field in the database that says this is an IMRT field. You actually have to pull a couple of pieces together to be able to do that. The vendor system doesn't tell you. So that kind of processing that we do to go back, we look at timelines for our patients. What was the ordering of what happened? That timeline isn't in the system. So we have to construct it from other data fields to be able to answer the question of what's happening for the patient over their treatment course timeline. So all of that goes into the processing, and then it ends up in our primary server, which at the moment is about 13 gigs. So again, not huge, but for us it's huge because it's all the relationships and it's everything. So we approach this, we look at database technology, and what should we be using? A couple of things are key. To benchmark, when we're looking at the options, benchmark it against clinically realistic data sets for clinically realistic questions, and ask how they fit into the whole process, right? We want to automate this process, so it doesn't do us any good to pick a database technology that's not going to integrate there. So yes, I'm a Luddite. I am an SQL user. But for example, here is a question. This is a practical one. So we want to iterate all of our treated fields. There's about 1 million realistic plans and courses, tens of thousands, and ask, how many disease sites got treated by day, and we'll do it in the worst possible way. So we'll make a crappy SQL command that's using an awful lot of outer joins. So we'll just push it and say, if we do that, how long is it going to take? So 1.5 seconds. Okay, that's fine, right? So do I need another technology that's going to not be easy to use as we integrate into analysis? No. So for now, we're using this. We're keeping an open mind as we're looking at other data elements. Will there be other technologies that we use? And that may emerge. But so far, in radiation oncology, most of what we need doesn't. The process of constructing these systems, we start down here, and you think you're going to go buy one. It's just not there yet. And we've seen this happen with a lot of technologies in radiation oncology. It's just not ready the vendors haven't constructed a system, so somebody has to start, and so we do. And as we start demonstrating value, then we're able to get more people participating on our end, and better perception in our community that this is worthwhile, that we've got more bang for the buck up here, even though with a relatively modest investment in a number of people. At some point, the vendors start saying, oh, this is making sense, and they start investing a lot more than we're able to do. But their solution's not going to have the bang for the buck that ours does. We know eventually there's a crossover point where there are enough people doing it, they've developed their independent solution, there's a vended approach to it that will work. Eventually the bang for the buck goes in the other direction. It just doesn't make sense for you to do it yourself. But the field is really right here, right now. We know this is coming, but not when. How do we, so in this process of going, for us, this starts with just a small number, and then it progresses. We've done pretty well over the last 12 months. Now we have a larger community that are doing this. But each step, we go through that cycle of get the data, use the data, prove value, then we're able to get more people involved. So after that first iteration here, this was like first contact. We hadn't hit warp speed, but we had got a lot of data. Now suddenly we were able to pull in some other people who could help us manage the data from Epic. And so this keeps expanding as this community grows, and we're able to add the data elements. We want to be able to use this. I know we're running short on time, so I won't go too far into it. We have now started using this data to develop automated approaches for analyzing it. So this was a bit of research we did a couple of years ago where we developed a software package that integrated C# code and R to develop an algorithm that detected dose response, right? I go too much on my lung dose and I get a toxicity. I want to throw in an arbitrary set of data and have it look for that crossover. Can I figure that out? In fact, it worked out very well. We benchmarked that with an SBRT data set, and so we had 26 DVH metrics, 11 structures, pulled out over 8,000 options in a few minutes. And from that, pulled out 7 structures that were highlighted as being significant for a dose response. So that we checked that well with somebody else's study, it turned out to be exactly the same in terms of what things were coming out. So it was like we developed something where you could shake it and out would pop what you wanted instead of having to piece by piece going through and picking it. So there's real promise for what can happen if you organize your data to develop these automated solutions. We use a variety of dashboards now to help our end users be able to get a perspective on the data and how things interact using Tableau. Okay, there we go. Recently, we've developed a statistical approach to characterizing our dose distribution. So in most treatment planning systems, all you ever see is that green curve. So I'm going to look at the dose to a parotid. What fraction of the parotid got this much dose? And so I know this much about it. In your head, right, our original picture, that's Avi, in his head, he's knowing what's high and what's low based on his experience. Can we draw that experience out of somebody's head and put it on the screen now that we have all the data that we've aggregated so we can inform them of where they are now with respect to historical experience and the objectives they had? And the answer is yes. So now we have a dashboard that lets us look at each of these structures. I can look at this curve. This is telling me the median value and then confidence interval, so I can see where this sits with respect to our historic experience. So this helps inform our clinical practice, right? This is one of for us, the wins. We have the data. We can fold it back into clinical practice. We don't want to just get the data. We need to do something useful with it. So this is one of the ways that we do that. We can use that same information to start quantifying practices. So if I go to hospital A and hospital B and they both treat, how do they compare? Can we have statistical metrics that can standardize no matter what domain you're measuring in, so it falls on the 0 to 1 score that characterizes your objective and your history for being able to make it. And we can use that, compare institutions, compare histories. How did we do early on? How did we do later on? So developing these actionable analytics that let us pull in the big data and then use it to guide what our choices is very important. We're using this information now, as I showed you the dashboards, but this is letting us reach out to other clinics, both to send them data, to look at pooled data, also to pull it back. So one of our projects is taking a look at head and neck data from multiple institutions and understanding practice norms. So this all sets the basis for being able to do that. So last slide.
Head and neck is a good example. You might take a cut right through almost 50-50, 60-40, HPV positive, not.
Right.
Heavy smoking, alcohol.
Right.
Do you do that routinely, or is that?
With what?
Do you do that routinely so you can get a
well, we are
of subsets?
Yes. So that's one of the factors that we're pulling in this particular study. That's pulled out so we can make that differentiation. Yes, you're exactly right, and HPV has emerged as an important factor. That underscores, though, one of the reasons why we want to make this automated loop. Because how do you know it's HPV? Well, early on, some people started seeing a pattern, and then they started gathering data. And if we had been in the position of that happening automatically and reliably, then you'd be in the position for that automated algorithm to say, hey, look, there's something happening over here. We don't know what it is yet. You're still going to have to do a real clinical trial and understand it, but you should look here because there's a pattern. And that will help us spot it. So I think that kind of thing could have helped us earlier on with the emergence of the understanding of the role of HPV in head and neck cancer. We'll understand more. That's one of our factors in this multi-institutional trial of head and neck, of things that we're looking at for norms. That will also help us understand geographic factors. So that's important to that question also. Great question. Thank you. So the farming really, is we're needing to pull together a community that supports developing what we're doing. So we have to get the nurses, the physicians, the administrators, everybody to see there's value. We have to close that loop. A farming methodology is really, or a farming model is better for expressing what we need to do. It helps them understand, why the variability kills us. Just typing in the free text you want to is convenient for you, but it means you won't be able to get at the data you want later on. So let's agree to standards that work for everybody. We have to figure out what those key data elements are and whether we can trust them, what their veracity is. The volume that shows up, for us in radiation oncology, we're not talking about terabytes. We get all of this data. It's fitting into a few, tens of gigabytes, 100 gigabytes. And it doesn't come in that fast. So velocity in the traditional sense of how fast it's being read into you isn't our issue. On the other hand, velocity in the analytics is. So that guides our technology database choices and how we're going to do the analysis. The physician wants to sit down, type, get the answer. So whatever we need to do so that that analysis can happen rapidly, that's really going to be the key value for us. And then we need to demonstrate value for using that data. That gives us the support to then go to the next step, go for the next data element, make the data set bigger, and increase the size of the community. So that's where we are with big data and radiation oncology. I think I've run a bit over, I'm sorry. Take any questions?
You're fine.
So tell me a bit about, because I'm interested in the parallels. So the things that we have run into with needing to recognizing we need rich cofactor profiles, and we need to understand the details of those data elements if we're going to be able to use the big data in a meaningful fashion. Are there analogs to the work that you all are doing? Or it just all comes out reliable and you're in a blissful world? Okay.
I have a question about
Sure.
how you address collecting good data to begin with. Aside from changes like to the EPIC interface to get more structured data and to validate the data, have you been successful bringing about behavioral changes?
Yes.
Do you participate like in clinical documentation improvement efforts and that sort of thing?
Absolutely.
Okay.
Yeah. So
Have you been able to measure the impact of that kind of effort to bring about the behavioral change?
great question. And so yes. So the places where we can close the loop, get the data, use the data, show the value, that's the place where we can start to get the buy-in. So for example, in that transition in how the diagnosis and staging was entered, which is necessary so that we can construct those survival curves, right? Not have it be based on 50, but have it be based on a few thousand. We measure now how frequently that happens, that they enter that information in and that it's connected up to the course. It's very high. And it's very high because people have been able to believe in connecting the dots to be able to do that. And it's important for us to connect them to make that happen. A place where we're developing it, this is another good one, is patient-reported outcomes. So traditionally, a physician will enter a toxicity. So this head and neck patient has xerostomia. So I mean, you've treated them, you've delivered a lot of radiation dose to the tumor, it's got the parotids and the submandibular glands. That means they're not producing as much saliva. That goes to likelihood of aspiration pneumonia, goes to problems with infection, and your teeth begin to decay, and your teeth decay, and you begin to have problems with infections. So there's a lot that happens from the xerostomia. You want to cut that down. How do you know? And so the physician has a scoring scale. We talked about that toxicity, 0 to 5, of the xerostomia. We know that. But one of the other things we know is that the patient's perspective may tell you something different from the physician's perspective. Right? The patient lives with that all the time, not just their particular slice of time. So we want to capture that information too. How are we going to do that? It's not a technology issue. So that's another place where it's tempting to think, oh, you just got to go buy this vended system. It'll do it. It'll all put it in the cloud, and you can download it, and you're all done. Not so much. Where's the data going to go? You run into compliance real fast. Where does that data live? Is it behind our firewall, or is it somewhere else? How much does it cost? Does the patient even want to interact with this electronic system that you've given them to put it in? What is your likelihood? You bring them in and you say, here, sit down. You give them the tablet. You can do that. They'll fill it out. What about when they go, a year later and they don't come back? Are they going to fill that out? Probably not so much. Who's going to talk with the patient and give them that tablet? So all of these things we have to deal with, not technical. Those are all the things that stand in the way of getting the data so we can ask the questions about it. And so we've now, it's taken us well over a year to get to that point. We're starting to gather it. Now we have to close the loop and go get that data out of Epic so we can then show it to the physicians to say it's worth our while that we did this, because now we have data that we didn't have before. And then we'll be able to measure compliance in increasing numbers of patients that take this. And then we'll say, well, we can go do another survey about a different set of questions, and so we'll be able to measure that increase in the volume of data. But all of that's coming not because of meeting technical challenges, but meeting challenges that are not technical.
Yeah, so the American Association for Cancer Research, which is a big umbrella organization for cancer research, participates in something called Turning the Tide Against Cancers. I'm sort of the lead representative. So one of our major outputs the past year and a half is on patient-reported data. It's a really coming thing. First of all, it's respectful of patients, and as you just said, it provides data you don't get from any place else, especially about toxicity and about acceptability of various kinds of procedures and advice. There's a much longer activity called patientslikeme.org, I guess, maybe .com. It was started by the brother of a young man who developed Lou Gehrig's disease, ALS. And it was pretty amazing 10 years ago already how much information people were willing to share. We're so worried about privacy and confidentiality for a good reason, but a lot of people, especially patients, those recede in the background when they want to know more and they have a lot of questions they feel are not being addressed and sort of being dismissed by the official professionals in healthcare. So there's a lot going on in this space, and of course head and neck is a very personal space.
Yes.
But it's true of most parts of the body, actually.
But I mean, one example where this comes up when you're dealing with sexual function, and where are you going to ask the patient this question? And you find, why were you giving the patient this survey when they were sitting in the waiting room with everybody else, right? So all of those other issues come up that you have to go to understanding the integrity of your data if you really want to know what it points to and how that is collected. But as you've said, it's going to be such a rich source of information. And once we get a pathway that works for being able to collect this data and be able to get other institutions asking the same question. So this is one of our topics in this data workshop, is what PRO should we use? Because if you ask one set of questions and I ask a different set of questions, and we can't find the merged piece. So we need the experts to find that consensus.
We had a seminar speaker yesterday from the New York Genome Center at Columbia University talking about big data and talking about accepting corrupted data or data with a lot of inaccuracies if you can have 1,000 times or 1,000,000 times the volume of data. Then you can take the inaccuracies and judge that to fall in the noise and mine all kinds of stuff. This sort of Google approach. And for certain kinds of questions, it seems to be reasonably productive. It comes back to the question of whether you have a hypothesis-driven analysis or you're waiting for the data to speak to you. You need good ears for that.
Yeah.
That approach, what he mentioned, that works only well for recurrence-specific issues on a population level. You cannot narrow down back to specific patients because.
So this is very important. Of course, this is all about individual patient care. In the end, in the clinic, in the analysis, if you're spreading it to the whole country, you can have big data.
Yeah. But
Better let people go.
Okay.
So why don't you ask your question directly?
Yeah, I'll just ask her
Marcus.
offline. That's fine.
Go ahead. All right. Well, then, thank you again.
Thank you.
Marcus, please.
What was the question?
One of your movements is trying to get away from a lot of free text.